Good afternoon from my side. Thank you for the introduction. I'd like to talk about the trial we conducted in the Inselspital in Bern about prophylactic administration of Terlipressin in patients undergoing major liver resection. No conflicts of interest to declare. It is known that after extensive liver resection, there is a strong hyperperfusion of the liver remnant and also elevated portal pressure. This leads to changes in the sinusoidal endothelium, as you can see on these images here, and in worst case, too small for size syndrome. Our group could show in previous mouse models that Terlipressin, which is a Splanchnic vasoconstrictor that is mainly used for treatment of hepatorenal syndrome, can lower portal pressure in mice after major resection. Based on this knowledge, we built the hypothesis that perioperative administration of Terlipressin in patients undergoing major liver resection could prevent postoperative complication. The Swiss allegory to this would be slowing down the avalanche going through the liver. So we did a randomized placebo-controlled trial with two arms, a control and a placebo group. We introduced patients that underwent hepatic resection of at least 3 liver segments. The intervention was an administration of Terlipressin 1 milligram every 6 hours for 5 days. Our primary endpoint was a composite endpoint of complications after liver resection, and the secondary endpoint were renal function. We randomized 150 patients. We followed them all up for 6 weeks. And in the placebo group, the drug was stopped early in 14 patients, whereas it was early stopped in the Terlipressin group in 21 patients. This difference is due to suspected adverse events of the drug that was in 12 patients in the Terlipressin group, but just in 2 of the placebo group. These side effects were mainly hypertensive crisis and arrhythmias. About the primary endpoint, we looked at liver failure, ascites, bile leakage, intra-abdominal abscess, and mortality. And if one of these complications occurred, the composite endpoint was reached. As you see, we did not find any difference between the groups after 6 weeks, so there was no statistical significant difference, not for the single complications nor the composite endpoint. We further looked at renal function, and we found a difference in the course of the glomerular filtration rate between the 2 groups. So patients in the Terlipressin group had a better kidney function after 1 day, 5 days, and even 6 weeks. This peak at day 5, we think, is due to a good hydration post-operatively and can be seen in both groups. So if I conclude, we can say that perioperative application of Terlipressin after major liver resection, which is defined by more than 3 segments, does not reduce liver-specific complications. What we cannot say from our study is if patients with more extended or extreme resections would eventually benefit from Terlipressin. However, Terlipressin has the potential to protect kidney function, and a selective patient population could eventually profit from that. I'd like to close with this image from the roof of the Inselspital in Bern, and thank you for your attention.
Please.
Henry Pitt, Philadelphia, U.S. Did you look at liver volume metrics before and after, trying to get any sense for an effect on liver regeneration relatively early or not?
We didn't in this clinical study. However, we did in the animal studies in mice we did before, and there we found better regeneration with terlipressin. And the endpoints here were really the complications. But of course, it would be interesting to know this as well.
I have one question. Did you measure the portal pressure and the gradient during surgery, before and after the appendectomy?
Yes, we did, but we had, like, as you know, it's a low pressure system, and the distortion or the values were not accurate enough to really have a clear result in the end. We found we could show the increase of portal pressure before and after surgery. This could be seen, but we couldn't find an effect of terlipressin directly on the pressure. But as I said, measuring intraoperatively in this low pressure system is quite demanding, and we had a lot of distortion or...
It may be interesting to analyze patients who have a portal pressure of more than 20 perhaps after surgery, if they benefit from terlipressin or not, compared to the others.
Yes, that should be done.
Okay, thank you. We have to